week. Okay? Yay! And you guys have already received the extra credit in the sense that we've already talked about it. Okay? So the diagram that shows all the different curves, what tidal volume is, inspiratory reserve volume is, etc. You have to know those, okay, for the extra credit. I'm going to give you that diagram. All you have to do is just label it, okay, the boxes. Make sense, everybody?
The exact diagram?
It's, yeah, so, it's that diagram with all the curves on it that say inspiratory reserve, blah, 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 okay? And then remember, I went over trachea, nasopharynx, you know, the pleura, the cardiac notch, etc. There was a diagram that was on one of the PowerPoint slides. You have to know that as well. Those are extra credit. It's 14 points, the extra credits, okay? So do it. And here's the reason why. Because on the remaining 2 unit tests and on the final, there is 0 extra credit, okay? It's the great equalizer. So 14 points, yeah. Okay, hold on, sorry. They're not here. Yes, they are. Some of you have shown me outlines, which is really cool. Don't wait to show me an outline Wednesday next week. From like noon, 3 o'clock in the afternoon on Wednesday, I will not even look at my email, okay? So you want me to look at outlines and stuff, if you have any burning, pressing questions topically, you have to let me know before then, all right? It's on chapters 21, 22, and 23. So let's go through the litany. There will be 7 questions you can hedge on. You can't hedge on true or false questions, okay? If you hedge, bless you, if you hedge, you have to give me an explanation on the same side of the answer sheet, okay? Not a paragraph, but a little blurb, all right? The case study and the extra credit case study are due at the beginning of class next week. They're due typewritten, handed in, not emailed, not faxed, not all the other stuff, okay? Let's see what else. What other nasty things does Joe have to say? Hey, Leslie. Oh, there are people who, speaking of Leslie, there are people who weren't here last week that I need to give you your exams. I'm going to do that at the end of the class. I have one person who did a write-up request, and I did that, and I will end that back to you, you know who I'm talking to at the end of class, okay? Are there any questions that anybody wants to ask? No? All right, well.
So the extra credits on the handout to give us.
Yeah, I'm going to have the extra credit like you did for the first test, Alicia. I'm going to have it attached to it.
Okay.
But you don't do the extra credit on that. You do it. I actually, what I'm going to do is I'm going to, that diagram with the curves and stuff, I'm going to just put like 51, 52, 53 in the boxes. And on the back side of your answer sheet, you just say what they are. Okay? Make sense? Yes, Margaret. And then you can.
There's no more extra credit. So what about the case study extra credit for?
The case studies have extra credit, I think, right? All of them. So there will be extra credit, but there will not be on tests 3 and 4 or on the final. Okay, Jerica?
You said 21, 22, and 23?
Yeah,
Okay.
exactly.
Thank you.
Make sense? Okay. So, any other questions?
Okay, so this is the diagram, but then you see there's something else.
Well, also the anatomy.
Okay,
Okay.
okay.
And so like there'll be an arrow, Alicia. What is this? Oh, that's the trachea, or whatever. So it's meant to be super easy, low maintenance, low threshold kind of thing. And always, from a test taking strategy perspective, always the first thing you do is just turn the answer sheet over and just do the extra credit. Why? Because it's actually, the extra credit is violating every principle that I believe in deeply from a learning perspective. It's intellectual anemia. And because it is, don't wait till the end of the exam before you write this stuff down. So you just won't remember it. Okay? Any other questions? Yes?
So the test is next Thursday.
Yeah, Jolene, it's at 6 sharp.
You're gonna give us the diagrams tonight? The
No, the diagrams are already in the PowerPoint. You have to find them.
Oh, okay.
Okay? And there's only, it's in chapter, I think it's actually in 21.
Yeah.
Okay.
All right, cool. Both of them are in chapter 21. I already went over them. All right? So that just means you have to find them. Wow, Brianna, that's amazing. Everybody, I'm going to collect some money for Brianna.
okay, that one, yeah.
Wow.
Yeah, that one, and then all that shit.
Okay.
Any other questions?
Do you want to take a picture of it?
I have it.
Okay.
Yeah.
And then.
It's in chapter
Yeah.
21.
Cool. Okay.
Yeah.
Got you.
All right?
You're welcome.
Thank you, Brianna. All right, so we are on chapter 23, PowerPoint slide 49. We have one hell of a lot of territory to cover. Here we go. Atelectatic disorders. I'm not pronouncing that again. What does that mean? That means that all or part of the lung collapses. Make sense? Atelectasis is all or parts of lungs collapsing. Okay? So, ARDS is the first one we're going to talk about. ARDS is adult respiratory distress syndrome, or acute respiratory distress syndrome. There is the infant version, which we're going to talk about. So the reason why, it's really acute, okay? But some people call it, I'm calling it adult, so you guys know that IRDS is for kids, okay? It's for infants. So, this happens a lot, actually, and I'm being extremely gracious by saying 30 to 60% mortality rate. Bottom line is, the minute it sets in, you've got precious moments before the person dies, okay? And all the data that I've seen, I mean, so every time I say something, there's always a walking example to the contrary. So a year or two ago, I said, it's like 60-65% of the people that go into ARDS actually die, okay? And a student came up after class, who was in a Patho 2 class, and said, I've been in ARDS twice because of my blank condition, and I'm here live, and I'm taking a test, but I might actually go into ARDS with the final exam, Jim, every class. And so people do make it. Again, that's the point. People do make it, but it's a narrow window. And honestly, I can't tell you what distinguishes those who make it and those who don't. Some people who have absolutely no reason in the world to be able to make it pull through, and others that you're like, you tell the family, this is tense. We're going to ask everybody to leave the room right now. But based on what we're looking at, there's better than a 50% chance we're going to be able to preserve this life. And you're like, what the hell happened? The person crashed and died, like instantly sometimes. Okay. And you've probably seen it, right, Chris? Yeah, it's frustrating as hell, okay? So, what are the causes? Trauma, okay? It's a big cause. I'm not going to talk about sepsis or gastric acid just yet. Fat emboli syndrome. I'm not going to say anything other than fat emboli. There are a bunch that get dislodged and go to a bunch of different places. You get blockages, massive immune system response, and that the person crashes. Shock. Well, we talked about shock, right? Okay. So, before sepsis, aspiration of gastric acid. Anybody who's here who has either you have, or you have a partner, or a loved one, family member, friend, neighbor, whomever, who suffers from GERD, or who's medicating their acid indigestion more than 4 times in a month. We're not in the digestive unit yet. that's the next unit. But if you're medicating more than 4 times in a month, your acid reflux. So Jim, I took the Maalox right after breakfast, right after lunch, right after dinner. That's 3 of the 4 for the month. You have to have that looked at, and you have to get it under control, period. I had somebody email me last night, a former student. Jim, I was recently diagnosed with GERD. I'm not giving up coffee and spicy food. What else can I do? So my email back to that person was John Dunn. I won't say his name. I said, John, when you're serious about asking intelligent questions, I'll reply. Okay? Why? Because you can aspirate your gastric acid. You've got GERD, you've got an ulcer, you've got esophageal varices, you've got hiatal hernia, blah, blah, blah. All the stuff we'll talk about in the very next unit. You have that stuff and you're only symptomatically treating it, the day's coming you're going to aspirate. So, here's a story, something for you to think about. My old man died this way. So, up to 82, my dad was the ethnic Marlboro man, okay? At age 70, 75, he was up in a neighbor's tree, 30 feet up off the ground, sawing a huge branch. My dad was tough as nails, okay? I've never met any human being who was that intimidating. He was shorter than me, twice as wide as me, half Greek, half Sicilian, fill in the blanks, okay? And he liked to eat what he wanted to eat. And my dad was never obese, ever, okay? I mean, his hands, his shoulders, he was just huge as a little guy. But as he got older, hey, it's America. I love ice cream. I love cheeseburgers. Dad, they don't love you. You can't eat it. Yeah, screw you. I'm going to eat it. Whatever. So, 82, he's an insulin-dependent diabetic. Okay? Everything went to hell after that. So, when you're a diabetic, you catch a cold. If you're a senior citizen, sometimes that means hospitalization, right? Okay. So he's in the hospital. He'd been in the hospital for 2 weeks. He's finally getting better. I talked to him on a Friday morning. Oh, that's right. When you're a diabetic, what's one of the other things that happens? That's right, the kidneys go. Sonic, after, come on everybody, let's do it. Sonic, let's celebrate. No thanks. No thank you at all, okay? But keep the U.S. economy and our jobs secure. Please go to Sonic after class. And so my dad was going through dialysis, and he wasn't at the point where he had to do the 4 times a week, the 5 times a week thing. He was doing it like once a week, once every couple weeks. He was sliding down that hill, okay? So, on a Friday morning, I talked to him, hey, I'm going to get out probably on a Sunday morning. You know, mom's going to, be here, she's going to drive me home or whatever, and we can talk about X, Y, and Z. Okay, cool, Dad, no problem at all. Sunday, great, okay? On Saturday, he was scheduled to be dialyzed one last time during his hospital stay, and then all was going to be well. He got home, as long as everything checked out, on Sunday morning. So, he gets rolled, he eats lunch, and he tells the nurse, and my dad can schmooze. And I just want to tell you too, my dad and I were very opposite people. Okay, everything was tough, that kind of. And not that I'm saying you don't have to be a man, but I'm just not into the macho thing. Just not. Okay, and my dad wasn't Jewish. My mom was Jewish, and so Greek and Sicilian, and my dad was from Greece. The island exactly between Sicily and Greece, he had a thick accent. Well, all the nurses, and many of you are going to be nurses, many of you are nurses, all the nurses loved him. So he schmoozed. Come on, I'm going to leave for crying out loud tomorrow. I'm a little hungry, a little extra food. So they stuck him a little extra food. Even though the chart I had written, and so did the other people in charge of his care, well, we keep him on what we're giving him, okay? So they stuck him some extra food. Sweet old ethnic man, really nice with the ladies, flirtatious in a benign kind of way. Give him some food. Put him on a gurney, Well, there's backup in the dialysis unit in the hospital. So he's with a couple other people in their gurneys waiting to get dialyzed. I'm a little tired. I think you can maybe roll the bed, lower the bed down a little bit. My dad was supremely technologically compromised, okay? So they put it down at about, I don't know, 20, 22 degree angle, and he fell asleep and aspirated. And he suffocated. He was without air for 8 minutes, okay? I was by that time back here in Albuquerque, and I get a phone call on Saturday afternoon. It's my mom. Hey, you need to talk to Dr. So-and-so. Dad's pressure is 40 over 20. They've been pumping him full of vasopressors, and my mom didn't say that, but vasopressors for about 25 minutes. The code team is in here. Can you please talk to the doctor? I had to actually make the call. No, that's it. It's over. Yeah, gamed it. Zap. Done. We're done. And my dad was gone. Aspiration. So you know what? Yeah, dude, I know it got GERD, so I bought extra pillows. Your brain is very smart. What does it do when you prop it up with extra pillows? You slide down while you're sleeping. So what do you have to do? You have to prop up your bed. Guys, GERD kills people if it's not paid attention to. Okay? For real. So ARDS, my dad went into ARDS. And he was in ARDS for a few minutes before any of the not attentive healthcare staff figured out, hey, the old guy looks like he's compromised right now, okay? And what did the hospital do? What hospitals always do, showered my mom with love. Every healthcare provider that had ever seen my father showed up at the funeral, bouquets of flowers, and I was like, you know what, right there, guys, you are all coughing up a huge check. But my mom didn't want to sue. So my mom is a much nicer person than I am. That's wrong. It's malpractice. Okay? Everybody all along the way. Starting with sneaking the extra food. You guys can work in a hospital, you're gonna have that all the time. Some patients are actually gonna be jerks about it. Hey, you call this food, this is shit, right? I want another something. Can't give in, or Jim's coming after you. For real, okay? All right, sepsis, we already looked at septic shock, right? This is obviously no big surprise. Somebody goes into septic shock, ARDS is almost inevitably gonna happen, all right? Don't look at that and get scared. What the hell's the deal with ARDS? What's its pathogenesis? The short answer is the inflammatory process happens. And I've said it like 8 trillion times this semester. So I'm just gonna say it. And what do we have here? We have inflammation. The inflammatory process happens. Non-cardiogenic pulmonary edema. What does that mean? It's not heart problems that are causing the vessels in the pulmonary vasculature to leak their fluid. The problem is in the lung tissue itself. That's the point, okay? And if the problem's in the lung tissue itself, that's non-cardiogenic pulmonary edema. So we get edema. Well, where the hell does the fluid go? In the alveoli and in the interstitial tissue. Does that make sense to you guys? Well, guess what? Yeah.
So that's how you get the wet lungs sound?
For ARDS, hell yeah. Yeah. You're ascultating. The minute you hear that wet lung sound, you're like, okay, everybody gotta be spot on. The key, Brianna, it's a great question. The key is ideally to see the person as the person begins to crash before the wet lung sound happens. And I'm telling you, if you ever have the experience, so you're looking at somebody, you know, you're at ICU, so you're looking out over the monitors, you're looking at your patients. You're looking at your patients, and all of a sudden there's somebody who's been relatively okay, and all of a sudden there's a sudden change. That automatically, maybe they fell asleep or something like that, but that means jump the hell up and go and take a look, okay? And no offense, don't trust your monitors. just saying, okay? So then what happens? If the lung tissue starts getting filled with fluid, you're not able to make surfactant. And even if you make it, it's so diluted because you got fluid. Does that make sense, everybody? Okay. Well, that loses its ability to create sufficient surface tension so that that part of the lung doesn't collapse. It's entirely possible when the person breathes out, because of the lack of meaningful surfactant, that area of alveoli collapse. Make sense? It was almost assuredly not going to pop back open. Okay? The other thing is, with the inflammatory response happening, remember we have neutrophils, we have all kinds of chemical mediators being released, we have material being digested, and we get fibrosis setting in. And remember, I started last week, chapter 23, restrictive lung disorders, by talking about fibrotic lung disease as the representative paradigm, right? Well, that's what happens. So, this is called a hyaline membrane disease. Why? Because we deposit fibers. If you're so the lung tissue is being ruined, and then you're depositing fibers in the lung tissue. When you deposit, when it becomes fibrotic, that means you've lost your capacity to adequately inspire air. Does that make sense, everybody? Yes? Okay.
You're not going to inspire or expire?
Inspire. Remember, we're talking about restrictive lung disorder. Obviously, in time, you can't expire either, but it's the inspiration that's the problem. Why is it the problem? Because we're destroying lung tissue by flooding it and having the inflammatory process and depositing fibers in the interstitium of the lung tissue itself while we're destroying the alveoli. Make sense? So while that's going on, what does that mean? You lost elasticity. You lost the ability to vacuum plane in to suck in air. Make sense? Okay, that's the problem, all right? So, I don't care about that. Decrease in lung compliance, well, I just said that, and that should be obvious, right? Okay. Decrease in FRC, well, we know, remember, this is a chapter 23 lung disorder, it's a restrictive lung disorder. Obstructive lung disorders, the capacities are all sky high, you can't get rid of the air. Restrictive lung disorders, you can get rid of whatever comes in, you can't get enough in. Make sense? Okay.
What's FRC?
So what is FRC? Anybody? Say it again. Reserve capacity. Yes? Yes? Make sense, guys? Okay, well, make sure it makes sense for next week. Okay? But yeah. Make sense, Brianna?
Yeah.
So listen. I hope the slide is next. No, of course not. I have an X-ray of this. And I can't remember if I got it from your book or what. So it says diffuse, fluffy, alveolar infiltrates. When you take an X-ray, what do you see? You see fluid and junk being deposited. Make sense to you guys? Okay. So early stages. So remember, you're sitting there at your station, you're looking at the monitors, and the patient suddenly changes. What's the change? It could be subtle, but they don't look like they're breathing the way that they were breathing a minute before. That's really the issue, okay? So the pulse rate might go up, it might not go up. I mean, eventually it's going to go up, but it might go up. So, hey, the patient's not moving, but the monitor's blipping a little bit more frequently, and they don't seem like they're happy like the way they were 5 minutes ago. Oh, they're just sleeping. Get up, go walk over, take a look at them, okay? If you can catch it early, then there's the greatest possible likelihood, there's no guarantee, but that's the greatest possible chance that you can actually get them back from the dead, basically, or prevent them from dying. So shallow, rapid breathing. So somebody's sitting there, right, in ICU, and all of a sudden, the minute that has, that's a change. get up, call somebody, do your thing, okay? Late stages, obviously shock sets in, so pressure goes to hell. The heart rate goes up, the breathing goes up, and they may actually be looking at you and be absolutely clueless where the hell they're at, okay? And even not responsive at that point. Don't care about these, don't care, oh, this is what, no. Hold on. There we go. I had to do it, I'm sorry, go back to the slides. Guys, look at this film study. What the hell are we looking at? Here's what we're looking at. There are fluids and proteins in the alveoli and in the interstitium of the tissue. And anybody's guess what this big dark circle is there? It could be, so the first guess, scar tissue, probably the correct guess. And if not scar tissue, it's a collapsed part of the lung. Okay? So one of the two for sure. Make sense to you guys? And you look at, so you can see the leads, right, for everything here in the film study. So is this an x-ray of somebody who made it? Probably not. Okay? So let's go back to 61. So open lung biopsy, so it depends on what's going on with the patient. I just want to explain why there's an open lung biopsy there. I mean, usually you're doing other things, right? But it depends how the patient got to ARDS. Sometimes what you do is you may have to bring them up to the cath lab, depends what's going on, crack chest open, boom, you're doing other things. When that happens, you might actually be able to do some sampling, right? Otherwise, you go through and get the sampling, but real honestly, guys, you get a film study like that, the last thing you're thinking about is doing a biopsy, right? That's something that's purely academic in nature, unless there's some other process also going on. So hyaline membranes, deposited fibers, okay? Cellular debris, right. What happens with the inflammatory process? We kill off cells. Which cells? The cells that didn't get enough oxygen, okay? And then interstitial and alveolar edema, well, that's how we got there in the first place, okay? The only thing I want to point out here is, so what are we looking at? So this is the interstitium of the lung. Jim, that's a blood vessel. That's not a blood vessel. That's actually an alveolus. Right. There's so much protein material that's been deposited there that what does that mean? There's no O2, CO2 exchange possible across those membranes. Make sense to you guys? And notice this is all bloated. It's filled with what? Fluid. You've completely lost the integrity of the structure of the lung. Make sense? Not going to test you on this slide, so relax. Okay? But I wanted to show you what it looks like. So, what do you do to treat somebody who's an ARDS? Well, if it's because of gastric acid and aspiration, you do suctioning, right? If it's because it's of sepsis, what do you do to try and get rid of whatever the microbe is? So, but that takes time, doesn't it? Right. So notice what else it says there? Mostly supportive. Want to keep your temperature right, their glucose level sustained, their body adequately hydrated, and enough oxygen going in. Make sense to you guys? So let me ask you a question conceptually before we do anything else here. If a person has alveoli that look like the ones I just showed you, and they have the film study that I just showed you, is O2 going to help them? No. Right, exactly. So ARDS is known as being refractory to oxygen supplementation. I'm going to say that again. It's that important. Task question, hell flipping yes, of course, okay? Here's the way it's gonna come, well, let me say this statement and then I'll give you guys a context for an exam question. ARDS, because of the process that we just got to talking about, is refractory to oxygen supplementation. What does that mean? So if I give you guys, here's the way it's gonna look probably. Give you guys some clinical scenario, somebody comes in, you suspect sepsis, or they're febrile, they're non-responsive, their O2 sats have gone to hell, their heart rate's sky high, they're tachypnic, and you see hyaline membranes. The single least effective thing to do would be A, B, C, or D. And one of the choices is, 8 liters of 200% O2 or whatever, right? And I mean, it's literally, I'll make it that absurd. I mean, some of you understand what I just said, 8 liters of 200%, but I mean, right, people do crazy shit, right? So Jim, the next question is, I've seen that happen, and we always put the nasal cannula on or the mask. Why do we do that? Lawyers. Wait, what did you just say? Lawyers, you heard what I said. Here's the deal, what happens if you actually can help temporarily bring them back a little bit? If you've got some lung tissue that's working, you want O2 going in, right? That's the reason, right? But since better than 50% of them die, and we know from doing autopsies, etc., we know that, and we know the process of the disease, O2 supplementation, you can do it, but it doesn't work, period, it doesn't work, okay? Oh yeah, block inflammatory cells. So what do? Listen, when somebody's in ARDS, you absolutely forego thinking about any long-term harm you might do them. If they have a living will that says use all efforts to maintain me, okay? And so, hey, the hell with it, who gives a crap, and give them a gazillion milligrams of steroid. Well, but it's gonna cause massive long-term problems, it's gonna shut their kidneys down. Well, they're not gonna be around to have kidney problems if you don't do it, right? That's the issue. So, what's one of the things that we use? We use jetted air, okay? Now I wanna tell you something. When we use jetted air, volume, ventilator support, positive and expiratory pressure. So pause for a second. Anybody, don't raise your hand. Anybody using the CPAP machine for obstructive sleep apnea at night? If you're using that, I'm not saying don't use it. By all means, continue to use it. I am not a physician in the state of New Mexico. I am a lowly community, part-time no less, community college instructor, okay? So, I'm not saying don't use it. I am saying all the data comes back. When you jet air in at high pressure, and we're gonna talk about infant respiratory distress syndrome, preemies, in a few minutes. When you pump somebody's body with air, you know which oxygen, and under high pressure, do you know what you do? You actually cause alveolar damage. So, what happens, then you have the inflammatory response. Oh wait, well we shouldn't do it then. Well, they die if you don't do it. Do you hear what I'm saying? So if you're able to actually save someone from the brink of going over the cliff at ARDS, if they make it, usually there are many system-wide problems the rest of their lives, starting with their lungs, okay? Does that make sense, guys? Okay. The high-frequency jet ventilation and the stupid machines for obstructive sleep apnea, if you've got yourself in a position where you have obstructive sleep apnea, you actually need the O2 because your body's actually cutting off breathing. That's what obstructive sleep apnea is. And how long are you without O2? Well, let me ask you a question. Do you ever want to be without O2? Does it matter what the answer is to that question? How long? It's minimal, 3 seconds, right? You want O2, so you can use the machine. But we're starting to gather data. We're starting to seek data in longitudinal studies now that show that that's actually causing long-term alveolar tissue damage. So what's the issue then? What do I do if I have obstructive sleep apnea? Lose a bucket load of weight the right way. Literally. Okay? Yes?
Are the CPAP machines like the high flow oxygen in the hospitals?
Yep.
Yeah.
Exactly.
Just like that?
So does it apply? Yes. Okay? All right. Infant respiratory distress syndrome. Well, ARDS, it's really acute, but I call it adult, and it's totally legitimate. For infant, it's IRDS, same reason, right? So there's distress, it's a hyaline membrane disease. We get to IRDS in infants a little differently though, and that's the reason why it's its own separate category. If a child is born before 30 weeks, and if mama is not treated before that delivery with steroids, so that the steroids go to the baby, okay? If mama's not treated, there is a better than 50% chance that that child is dying, period, okay? But I know it doesn't matter, I'm talking statistically, right? So the 1 or 2 or 5 or 10 stories that you guys may know, which are awesome stories to know, thank God, they don't count statistically. They don't change the statistic, rather, okay? So, right before mama gives delivery to that preemie, if you give mama a big dose of steroid, you literally, look at this, you don't eliminate mortality, but you dramatically drop the likelihood of mortality, okay? So, how many of the kids died where mama got the injection of steroid, or it was put in the IV bag? Only a third, whereas it was almost 2/3 before. 50% reduction, that's massive in medicine, okay? If a child is born just before 34 weeks, there's a 1 in 20 chance that that child will die, okay? So, the closer to 40 weeks you get, the greater the likelihood of mature lung tissue, surfactant, and everything, okay? So what are the risk factors for IRDS? Being born before 25 weeks, okay? Why? Well, the very first chapter we talked about for this unit, what did I say? That there was the canalicular period, remember? And then the issue is by between 16 and 25 weeks, that's when we start developing the tissue and it starts to thin out, but surfactant the cells that make surfactant don't really come online till right around week 24, week 25. Make sense, everybody? Okay. Birth at advanced gestational age. In this state, we have an unusually high number of females who give birth damn near close to as 42 weeks as possible, okay? The good news is that if it's not over 42 weeks, there may be other issues, but at least the lungs and the capillary beds are about as developed as it can possibly be. If, however, the child is in them hours more than 42 weeks, things start to go to hell. It's a different mechanism, but bottom line is that that child's at risk for IRDS. Even if she was 13 pounds and 20-something inches long, because mama, didn't go into labor a long time, yeah, that child's at the same risk, okay? Mechanism's different, and I don't want to talk about it because it's confusing, right? Yeah, right.
My brother actually had it, and they actually pierced his lungs, break like this breathing form. This is a long time ago.
Wow.
A day, and he lived, and
that's cool.
he got scarred, tough as nails, but I was just like crazy.
So he was over 42 weeks?
I don't know if he was, I thought he was preemie.
Oh, okay. Oh, cool.
So maybe he wasn't.
Okay, cool. And so, if you don't mind me asking, how long ago was it roughly?
Like 2-year thing?
I love him automatically. Okay, so at that time, we approached the issue a little bit differently, so you heard what he said, right? They went in. Now what we do is we jet a bunch of surfactant in. Was he, do you remember how creamy he was?
No, I mean, I just hear the story.
Right.
From my mom mainly, there's no real
Right,
concrete installed.
right, yeah, gotcha. And I appreciate you sharing that, Brent, big time. Well, so, there's a story, they lived. I was actually, I was pretty close to term, but probably 2 to 4 weeks early. And that's where I lost the height. Just want to throw that out there. Okay. Thanks, Mariah, I appreciate that. I was born in 1961, and my mom was in labor like 37 hours, and then they made the decision to do a C-section. And why? Because at the time C-sections weren't. C-sections are not routine surgeries, ever, okay? That's a misnomer. But at that time, they were comparatively new and super scary and dangerous. And when I came out, I was completely purple and blue, and they couldn't get me to gasp for air for 10 whole minutes. And my mom told me when she gets pissed at me that I obviously suffered profound brain damage at that time. So I was like, thanks, Mom. Firstborn, really appreciate that. But, so some people really do make it when they absolutely shouldn't make it. And the people that should make it sometimes just don't, okay? I've seen preemies at 35, 36 weeks die when they got all the right care. Michael?
I just have to share, because I work in the NICU myself.
Oh, wow, okay.
So last night, when I worked, I had a mom that was past due, and then the baby came out. And I had to do the whole thing pretty much doing that whole.
Wow.
And then baby got CPAP and all that. So everything was
Right, it happened last night.
yeah.
Wow. So, I mean, listen, sucks for the family, sucks for Junior. Super cool as a healthcare provider that it happened. So the CPAP, yeah, that's going to actually cause long-term problems, respiratory problems. Now, listen, there are some people that go through it that are born 28 weeks, they get CPAP, they're in the incubator for 2 months with jetted O2, right? Live to ripe old age, they're perfectly healthy, God bless. But that's the outlier statistically. That's not the norm statistically. Because when you have to force in air in underdeveloped lung membranes, what you're doing is you're irritating the lung lining, and then what happens? I know, it sucks. The inflammatory process. For real, okay? And that actually destroys lung tissue. So those people might have asthma or they might develop chronic bronchitis. Well, Jim, I said 90% of the people that have it are smokers. What about the other 10%? Well, that's from everything, right? Okay. So, what are the high risk factors for having IRDS? C-section without antecedent labor. Jim, what the hell? Well, an emergency surgery, right? Mom's in a car accident and she's hemorrhaging terribly and she's pregnant. You perform the C-section because you want to try to save both, okay? That's a classic example. Another example is, and I'm not kidding you, in the 90s when I was getting my training, wealthy moms were able to schedule their C-section on their Franklin planner, because everybody has to have a Franklin planner if you're, anybody. And hey, I've got this ski trip to Vail. I want my little, tummy bump to be down by that time. So can we do it like next week? Yeah, we'll do it next week. Okay, cool. So a lot of people did that, and then we got data on those kids. And those kids actually ended up suffering profound respiratory problems for many years, okay? So now, if it's not an emergency situation, or if it is, but not, baby's gotta come out right now, you stick a Pitocin drip on mom in the operating room and you get her to start having some wild contractions, even if it's just for 15 minutes, so that you can get a C-section where you don't have this problem, okay?
How long would you say someone could or should be in labor before going to C-section?
I'm not an OBGYN, and I defer to my brothers and sisters who are. So that one. David?
Might be a bad question, but what about a C-section makes it more likely to have this or any other?
It's not the C-section, it's not having the antecedent labor.
Okay.
That's the issue.
How would the labor prevent any kind of?
Excellent question. So when we have labor, what's the single most traumatic event in a human life? From the physical, I'm not making light of death. Everybody who's been dear to me when I was growing up died. Okay, so I'm not making light of death. But the reality is, when you die, I don't care what's beyond the grave. So I'm not meaning to be offensive, I just don't. Okay? So when we die physically, there is no more life. So no matter how tragic the death was, at least you don't have to relive the stupid experience, right? So what's the single most traumatic event physically in a normal life? Being born. We have a catecholamian explosion that shuts the shunts, right? The fetal shunts, and helps everything come online. Make sense?
Yeah.
Now, you can do antecedent labor at 28 weeks, that's not gonna help things come online. Make sense? Oh, you're very welcome.
Just like, out of curiosity, when like the baby's breech or something like that, can say through the C-section, they should still do
So, so listen, when a baby's breech, a lot of times babies have been breached for a long time. Statistically, that's not the majority. They're like my antichrist child. Okay, Tara? So it's like, sweet! This, I was in, I wasn't scrubbed in, because it's not gonna be an operation, right? Izzy's gonna come out, no problem at all. I actually looked at my wife's abdomen as we're getting my wife prepped, looked at my wife's abdomen and was like, oh my God, she just went breech. And that's usually what happens.
Well, my sister was breached the whole pregnancy, that's why.
Oh my gosh.
Yeah.
Right. Well, did she have any labor at all?
I have no idea, I should probably know.
No, it's okay, it's fine. So here's the deal though, the child's breech, odds are pretty good that they had that your sister and people who had babies who were breached for a while, they probably had a whole lot of false labor because the breech position tends to trigger that, they're fine. Does that make sense? It's a hell of a good question. Right, yeah, exactly. Last question so we can go on, Brianna, or statement.
How did they give surfactant?
I'm gonna get to that, Brianna. Good anticipation, I will, I promise. Previous infant, so second twin, obviously, why is a second twin in trouble? So the biblical story of Esau and Jacob, I'm not preaching religion. I can say because it's a Jewish story, right? So my name really, so there is no way, my mom fooled my dad, okay? My dad said, he's got to be named Demetrius, and my mom was like, hell no, okay? We're going to call him James. And my dad was like, oh yeah, okay, cool. So and neither one of my parents, both my parents were atheists for many years, so when I was born, they were atheists. But, so my dad was like, okay, cool, because, James, hey, that's the name of the Bible. My dad was not a religious man. It's just that if you're Greek, you have to have a biblical name. It's what you tell your relatives. You know how you say James in Greek? Iakovos. You know how you say Jacob in Greek? Iakovos. And Jacob in Hebrew means the deceiver. Second twin, the deceiver. They camp out in the womb a little bit too long sometimes. Does that make sense to you guys? A lot of people's like, sweet, the first one came out, everything's going to be hunky-dory, no problem at all, the second one's coming out. You make sure mama delivered that second baby lickety split, because the longer that kid's in, how long? No two human bodies are the same, right? So the longer that kid's left in, the greater the risk of IRDS. Even if they're term, even if they're full term, okay? Previous infant with respiratory distress syndrome, don't really understand what the cause of that is, but that might be, hey, maybe mama's womb isn't doing the right thing. She wants to, deliver baby maybe a little bit too early or something like that. So if you have a mom who's had a child that had IRDS before, she's monitored very, very carefully so that the baby's monitored very carefully, okay? And then obviously RH factor and compatibility, that's a no-brainer. So how can you tell that this child is experiencing IRDS besides the fact that they're really immature and they're really small? Well, what you do is you see their chest progressively sucking, gasping, and maybe even a seesaw movement literally in the chest. Because if they don't have enough surfactant, every exhalation closes a few more alveoli. And then the child doesn't realize that that's the case, but because so much of breathing is automatic, the child is trying to generate enough extra pressure to pop open those atelectatic alveoli. Does that make sense to you guys? And once one alveolus collapses, it's like dominoes for the rest of them. Does that make sense to you guys? So you have to actually administer, and we're going to talk about it again in a second, okay? So look at this. The neonate has to generate extra pressure to open up. Yeah, guys, listen. What did I say for an adult to cough? 100 millimeters of mercury. Remember, I made a big deal about that. You coughing for a long time, over a period of years, you put a lot of pressure on the pulmonary vasculature and on your heart, right? Well, a newborn it's preemie, that doesn't have enough surfactant, has to generate 25 to 30 millimeters of pressure, which doesn't sound like a lot. That's just to pop the damn alveoli open again. But as more close, the pressure curve goes up, and eventually they can't open them up anymore. Make sense, everybody? Okay. Don't care about that. So, remember when we talked about chapter 21, when we went through the non-pathological stuff, I said, it's important that the alveoli, that the lungs are sufficiently developed so that surfactant can get made. But remember I said that's not the only consideration. The other consideration is, are the capillary beds sufficiently mature and have enough of them developed and branched so that even if there's enough surfactant, there's enough blood that can be whisked away that gets oxygenated. Does that make sense to you guys? So the two big issues with being born preemie, one is, do I have enough surfactant? But even if you have enough surfactant, the second consideration is, do I have enough capillary beds? And are they sufficiently mature enough, listen, and thin enough so that passive diffusion can happen the way we talked about? You guys with me? Yes? Okay. So it's the same stuff. You get the inflammatory process that's in. Everything else pathogenetically is exactly the way ARDS is. Okay? So what do? We do FiO2, forced inspiratory O2. Okay? CPAP stuff, right? Jet it in, but that causes damage. Okay? So how can you tell when a child is experiencing, again, so listen, if Shaquille O'Neal and his wife, or I guess his ex-wife now, had a baby, at term, that baby's not going to be 5 pounds in 8 years as one, right? So if whoever the mother of his children was, I don't know if they're married still or not, but whoever she was, if baby came out and there was some ambiguity about like what the real due date was, and baby comes out as little baby Shaquille, Now, a little baby Shaquille is 17, 18 inches long and 4.5, 5.5 pounds. Odds are pretty good just from context. That baby's probably a little bit premature. Okay? So let's say you're working on the floor that night when that baby gets wheeled in, and everybody's taking pictures. Oh, everything's really sweet. And what happens is you notice over a period of hours that the baby begins taking progressively shallower breaths. So you open up the blanket, you auscultate and listen, and what do you hear? Well, it's not so much what you hear. You're looking at the baby and you notice the nares, the nostrils are flaring. And what you notice is that you see the rib cage go way in and then tries to get jutted way out. Way in and way out. And then it becomes asymmetrical. Does that make sense to you guys? Well, you might even hear grunting. That's a good indication things are going to hell. You take the child's temperature and you notice that the child is, instead of at 98.6 plus or minus a degree and a half, you notice that they're at like 96.2, 96.5. You're like, okay, that's a little weird. Why is that the case? Because the blood's not getting oxygenated sufficiently, and as a matter of fact, a bunch of it's getting shunted away from the lungs. Why? Because now you have patchy atelectasis. Parts of the lungs have collapsed. Does that make sense to you guys? Okay. And then, for real, Jim, you see 120 breaths. You can see 120 breaths a minute. Oh, hell yeah. And by that point, we're looking at the morgue if there isn't radical intervention right away. Okay? So grunting sound, seesaw motion, that's the asymmetrical motion I talked to you guys about. Blood gases, I don't care about blood gases. Chest x-ray, the same like with the ARDS. Okay? So we call that diffuse whiteout or ground glass, that x-ray that I showed you of the adult in ARDS. Okay? Why? Pulmonary infiltrates. Okay? So before mom gives birth, you do an amnio. Now, I'm not saying that amnios are risk-free. They're not. Okay? But if you suspect that mom is in labor or whatever, there's a situation where the baby needs to come out. If you have some time to be able to gather some empirical data you want to, so you do the amnio. What are you looking for? The lecithin to sphingomyelin ratio. You have to know this. If you see a ratio that's greater than, or 2 to 1's okay, but ideally higher than that, in the amnio, then you know that there's very little likelihood the child's going to be born with IRDS. So you don't think premature at all. Okay? Baby has to come out, baby's got to come out. What's the deal? If you have desaturated phosphatidylcholine in the amnio, if the lecithin is at least twice as much prevalent in the amnio as the sphingomyelin, what does that mean? Hey, those are the biochemical byproducts of mature pneumocytes or alveolar cells. Okay, does that make sense to you guys? That means, hey man, there's surfactant in them, their lungs, and the capillary beds are probably adequately developed. Make sense? Okay, yeah.
You said that was 2 times as much?
2 to 1. 2 to 1 ratio. So the 2 to 1 means the lecithin is at least 2 times as much as the sphingomyelin.
Okay.
Make sense, Jerica? Okay. So less than 5% chance. That means there's still a chance because if the kid's preemie, there's still a chance, right? But it's almost negligible from a healthcare perspective. So prevention is a primary goal. I already talked to you about if you do FiO2, you cause damage, positive and expiratory pressure, mechanical ventilation. I've seen it all. And guys, yes, it's awesome that we can do that, but holy crap, can it generate some long-term respiratory damage, okay? So, Brianna, Here we go. So what do? It lands up. Have you ever been part of a team administering it? No? Okay. So it gets atomized, right? Just you atomize it. You literally, so a thumbnail's worth is about $20,000 right now. And it gets stuck. You carry it on all choppers in the state because there are lots of kids that can't get to hospitals in time. And you aerosolize. It gets aerosolized, and the kid inhales it, and it's absolutely crazy because this chest, this blue, purplish hue, and the chest is heaving, literally within a matter of several minutes, completely calms down and is actually breathing. It's really amazing, okay? And so we have bovine, cow, porcine from pig, or synthetic, and they're all relatively the same efficacy. And this, administering that has literally cut mortality in half.
So kind of like an inhaler then?
It gets aerosolized like the product coming out of an inhaler, but it isn't an inhaler. Because actually the tube goes down into the lungs so you can jet it in. Make sense?
Yeah.
So, and then, okay, so sweet, you got surfactant in there, kids breathing, fine. You get them off the chopper, let them stay, in Budia or whatever, okay, on the way up to his house, down by the river. They have one shop there, mostly nurses, that are the primary care people in that area. So we need healthcare providers who know what they're doing. So yeah, okay, cool. So surfactant was administered, everything is fine. Wrong. It works, it's in there, it works, that's awesome, but the kid still has immature lungs, and the kid still needs jetted oxygen, and the child might, very realistically, will have a problem sustaining a glucose level until they get out of the incubator, okay? So you need constant O2 until they don't need O2 anymore. How long are they O2 dependent? Depends on each kid, okay? So, obviously you want to give a lot of times, if it's a really premature kid, you just stick antibiotics prophylactically into the bag, right, Michael? You guys see it at the hospital. You stick it in the bag, why? Because if a child was born preemie and there isn't enough surfactant, odds are pretty good there's microbes there. They can't get out, okay? And then the rest is supportive therapy. Notice, minimal handling, okay? So my peanut daughter, my oldest daughter, who's 20, who stands on a warm day, maybe 410, okay, maybe, who's a junior in college already and is flying back tomorrow night for her fall break. When she was born, I'm not kidding you guys. So she was like 7 pounds and like 18 and a half, 19 inches. She was a peanut, but the weight was good. But she couldn't sustain a glucose level, so not a big deal. And so they put the IV in. Twice in the first 12 hours of life on the planet, she pulled the IV out. Twice. Some compassion for the old guy. So we had to splint her arm to keep the IV in. And she had a hell of a time for 4 or 5 days breathing. And so now the kid has pretty bad asthma. She developed it a long time ago. That was just 5 days in the NICU, okay, not here, back in Chicago. And she's only, 4'9". And, yes, it's true, I am Frodo Baggins, right? But I mean, everybody in my family, demon child, like towers over her sister, which she enjoys, of course. But I mean, nobody's that short. Why is Ariel that short? Well, I know why. The oxygen, developmentally, things got slowed down. And then it kicked in. So she's 4'9". Okay? 4'10", sorry. 4'10". Does that make sense to you guys? So minimal handling. My wife stayed in the hospital for 2 days because my wife had some issues as well. So she stayed in the hospital for 2 days, and she was like, well, can't you just take her out? The doctor said it was okay to take her out. You're not touching her. Why? Minimal handling. Why? Because what do newborns do? They're fussy. Their sensors have not been habituated. Oh, that's a nice touch. That's mom, okay, who I will manipulate for the next 50 years. I didn't say that, did I? Okay. No. Right? They don't know. They get touched if they're hungry, right? Why do little kids cry? Because they don't understand the sensory input yet. They haven't learned what it means. And when they cry and they fidget, that increases oxygen demand, and that's the problem. So then what hit? Does that make sense to you guys? Okay. Pneumothorax. So remember, there is this pleura surround the lungs, right? And the pleura are bilateral. There's the visceral, so here's a lung. I can't draw it right. Okay? There's lung. There's a 2-layer membrane around each lung. And they're not separated that much, obviously. But that part that's directly against the lung, visceral pleura, the part that's right on top, parietal pleura, right? So there's this space right here, and that's the pleural space. So, if air gets in to that space, that's a pneumothorax, okay? And a pneumothorax is a medical emergency in most instances. There is a primary pneumothorax, and remember in medicine, primary means it arises in the tissue itself. Secondary, something happens elsewhere that brings about this effect. Does that make sense to you guys? Okay. So, there's the minority of pneumothoraces, and those are called primary, as a primary pneumothorax. And so those happen spontaneously, and almost always it's a young male who's tall and thin, 20 to 40, so young adult. I mean, women get it too, but usually it's this. And they have absolutely no underlying problems whatsoever, except that they smoke. That's it. And then, all of a sudden they get a pneumothorax, and if the pneumothorax is substantial enough, it can kill the person. Okay? So secondary pneumothoraces, that's what you guys are going to see more of. There's a zillion ways you can get them. So that can cause anxiety to fellow asthma sufferers. If you have asthma, you are at risk for pneumothorax the entire rest of your life. If you're a poorly managed asthmatic, it's a higher risk. So if you have your rescue inhaler and you can't breathe, use the damn thing. Address the triggers, but use the rescue inhaler. Why? Because if you don't use the rescue inhaler, you're gasping for air. So listen, what are we talking about here? This is a restrictive disorder. Can't get air in. Asthma is obstructive, right? But what happens is when you can't get air in asthma, because you can't get it out, so therefore ultimately you can't get it in, right? When that's developing, when you have asthma, you're putting great strain on the pulmonary vasculature. You're putting great strain on the lung tissue itself. And we've got these weird things on our lungs, deformities, called blebs. I'm not kidding you, that's what they're called, okay? And where there are blebs, there are little outpocketings or even invaginations of tissue that's thinner than the rest of the tissue. So there's structural abnormalities. So you're going, or you're coughing a lot because you've got asthma and you're not taking care of the symptom. That might generate enough pressure in millimeters of mercury to cause one of those blebs to rupture. If the bleb ruptures, air goes in. Because remember, in a healthy lung, in this pleural space, there is always a -4 millimeter pressure drop compared to what's inside the lungs. Okay? In the pleural space, there's always a pressure drop. It is historically always roughly 4 millimeters less pressure than what's in the lungs. Well, what's in the lungs? Whatever the atmospheric pressure happens to be, wherever you're at. Okay? So, if you have decreased pressure, think about it. It's just air going down the left. It's pressure gradient. higher pressure on the outside, you open up a door to the pleura, lower pressure on the inside, where does the air go? Into the pleura, and it fills it. If enough air goes in there, what does it do? It squeezes the lung and causes the lung to collapse. Does that make sense to you guys? Yes? Okay. People who have emphysema are at risk, people who have cystic fibrosis, TB patients, patients who have pneumonia. Patients who have pneumonia oftentimes think that one of their lungs has collapsed because it's so painful to have pneumonia, and that's something you have to obviously pay attention to. So, not to make anybody have anxiety, but we've got to talk about this. So, there's this thing called the catamenial pneumothorax. I just want you guys to know it. People who have endometriosis, and what's endometriosis? That's just there's tissue somewhere other than in the womb that responds to the hormone cycles, and therefore you can have bleeding in areas where there should be bleeding. Okay? So people who have even mild endometriosis are at a higher risk of having a pneumothorax, and especially during the time of menstruation. Okay? That's all I want you guys to know, and I'm not answering any questions about that. Okay? There's tension pneumothorax, and so what's the deal with tension pneumothorax? It's just there's some trauma. Now, obviously, if there's a puncture, person gets shot, the bullet goes right through, rips open the pleura, well, that certainly qualifies, right? But what about the person who doesn't wear, and I don't know, we have a plague of idiots in this state who don't wear seatbelts. Okay? Seatbelts, man, they confine you, and I know somebody who got trapped. Okay, whatever, then don't talk to me about that, okay? Because I will be super hostile back. Bottom line is, you hit the steering wheel. You hit the steering wheel, and you're going 30 miles an hour, and you come to a sudden stop, and you hit the steering wheel, you're going to have some trauma, right? So you don't have to have a penetrating trauma. It could just be super high pressure. So, Odiabo, I think that's how you pronounce it, the guy from the Seattle Seahawks, when they played, I can't remember who the hell they played, I think it was the Colts. He got hit really hard in the sternum. And they thought that he actually ruptured his aorta on the field, but it wasn't a ruptured aorta. They whisked him away to an emergency room. I think it was in Indianapolis, but they whisked him away to an emergency room, and he stayed there for a day and a half because they were concerned that he might have had, and he literally said, "I can't breathe. Oh my God," and he like fainted. And so, oh my God, maybe he ripped his aorta, or oh my God, maybe he developed a tension pneumothorax. As it turns out, he didn't have either of those two. He had what the team is calling a bruised sternum, and yes, he played the next week. So, whatever, okay? So, how do you get it? I talked about the blebs, okay? So the primary one is the blebs. The secondary one can come from the blebs. Remember, secondary, something else is causing it? So what if it's induced by asthma, this pneumothorax? How did that come about? It might just be all the freaking higher tension in the pulmonary vasculature that you're untreated or unresolved, or you're extremely symptomatic asthma is bringing about. Does that make sense to everybody? Okay. So, ipsilateral means same side. So let's say this is a patient's right lung. Bleb ruptures, whatever, air comes in. If enough air comes in, the air is going to go down this pressure gradient, it's going to fill the pleural space. The pleural space is going to push on the lung. All the air that's in the lung is going to go out, and that lung is going to collapse. So, if you get a tension pneumothorax on the side that you've got the tension pneumothorax, ipsilateral atelectasis. The technical phrase, you have to know it. Ipsilateral, terms there, atelectasis, I mentioned a bunch of times. Okay? Here's the thing that's weird though. Everything in the chest is pressure gradient, right? So you know what happens? Ipsilateral atelectasis, contralateral deviation. So the great vessels, they're in the superior mediastinum, get pushed to the other side. So if it's the right lung, we have right lung atelectasis. If you do an x-ray on this particular patient, what do you see? The trachea is deviated all the way to hell over to the left. Oh yeah, and so may be the superior vena cava, which is massive unhappiness, because if it's pushed over, that means it's pinched in some way, there's some compression, which means that blood isn't being delivered adequately from the brain, the head, the neck, shoulders, and the arms. It's not returning to the right atrium effectively. Cardiac output has gone to hell, and shock sets in. Does that make sense to you guys? Okay. That picture demonstrates it. So, is it possible to have a small pneumothorax? Hell yeah. Some people, and seriously, some people come in, you do a film study, or depending upon what the presentation is, all the right words are said. And if the right symptomatology is present and the patient is coached to know what to say to get attention, because that never happens, right? Okay? And they get, instead of getting an x-ray, they get a soft tissue study. They get a soft tissue study, which are far more accurate, and what do you see? Oh my God, 20% of their lung is on the way to being collapsed because, on the right side, they've got roughly 1/5 of the total space is occupied with air. How is it possible that the rest of it doesn't get occupied with air? It might be a low of the patient, adhesions, all kinds of things. Does that make sense to you guys? And the patient might be completely asymptomatic. All right? So you literally can have, I'm not saying everybody's asymptomatic who has 20%, but you can have up to 20% pneumothorax and the patient's not symptomatic. The ones who begin to get symptomatic are their heart's beating faster because you're not obviously doing oxygenation the right way. And when you auscultate them, listen, if you have atelectasis in the base of this guy's lung, or this woman's lung collapse, are you going to hear any breathing sounds? No. So when you don't hear breathing sounds through the stethoscope, you know that at least that region, there's something wrong with it. If it's a pneumothorax, well, you've got collapsed lung or collapsed partial lung. Make sense? Why is there, though, on the contrary, hyperresonance? So, you do that, right? There's hyperresonance. Why? Because that side is bloated out with air now because it filled the pleural space. So of course you have hyperresonance. Does that make sense to you guys? If instead you suspect that it was blood or fluid that went in, it's dull to percussion. And there's still no breath sounds. Make sense to you guys? Okay. And a pneumothorax is not something that develops very slowly. Some event happens and all of a sudden the person's like, oh my God, I can't breathe, or whatever, okay? This poor guy is, I think, cited in the book for 15 million things, okay? You can tell, remember when I talked about chronic bronchitis, blue bloater, that's the patient we looked at. So think about that when you light up, just saying, okay? So listen, when you do the chest x-ray, and I have a film study that we'll look at briefly, but what do you notice if it's unilateral pneumothorax with atelectasis? So one side and only one lung collapsed. What do you see? What you see is, besides that there's the lung collapse, which I'll show you, you see that the diaphragm on that side is actually dumbed down. There is no ability for it to contract, and it's already pushed down substantially. It's flat. Why? It's pressure gradient, guys. Does that make sense to you guys? So what does that mean? That's why it's in chapter 23 for restrictive lung disorders. That side, well, you can't get any air in. I mean, there's no place for the muscle to move because it's already down. You can't create enough pressure to get air to come in. okay? So, in this slide, the collapsed lung is here, okay? How can you tell? Well, you see some vessels there that are shifted this way. That's a freaky slide, okay? That's a scary, scary, scary film study. The other thing that you see, just to be thorough, is you see pulmonary infiltrates all over here. So this is probably somebody, so they're in ARDS. They had a, whatever, probably had a tension pneumothorax, lung collapses, pulmonary infiltrates in this one. You have contralateral tracheal deviation, and now we've got pulmonary infiltrates, so the other lung is ready to go to hell too. Make sense? Everybody, yes? Okay. I'm not giving you a film study to look at on a test. I just want you to know what it looks like and to understand the terms to be able, so I can describe it to you and you can answer your question. Make sense to you guys? Okay. I'm not gonna test you on this, but obviously, guys, if you have lung issues and you have inspiration and respiratory problems, what does that mean? You have heart problems, right? Because you change hemodynamics. And you have oxygen deprivation. What do you do? Well, if you have greater than 15% collapse, how is this shit figured out, Jim? Well, each unit has its own way of looking at it, okay? Way beyond the scope of this lecture. But if you have an adult, that's the key, who's got greater than 15% of their lung is collapsed, what do? You put a tube in and you reinflate the lung, basically, okay? So, can you solve their problems that gave them the pneumothorax? Yes. All kinds of cool stuff. Go in and do staples, but staples, for some people, it's not something you can do. So, chemical pleurodesis. So, what is that? You go in and you actually cause adhesions to form, and it's like soldering the separated parts back together again. Does that make sense to you guys? Okay, cool. Pleural effusion. So you know what, let's take no more than, yeah, Chris?
So when you solder them back together, you say that's a weak spot. Is that going to cause them to be like activity limited severely, or will they ever be able to be normal again?
That's a phenomenal question. So it depends on how big the rupture was. Right, I mean, the bigger it was, the less elasticity there's going to be. So not only are they at risk for a future rupture, you're also potentially diminishing total possible lung capacity because of the restriction, the lack of elasticity, right? So that's a great question. So just 3 or 4 minutes, I'm going to start up again right away, because we still have to consider I think so. No, it is my thing.
How are you?
Right.
It's there. How about you?
It's in yeah.
We got lower
You
you.
have to know each thing represents like vital volume, et cetera. And then you kind of know the picture that's in the same chapter of the slides of the lungs. You know, all the anatomy, professional girls and focus on parts of the anatomy.
I don't want to do
But it's all in chapter 21.
I want to explore that I'll tell you about. I'm just like, well, and it's funny because they're all fighting for my Mondays. Well, on the work all the time. So they all were like excited when they heard it was going off on Mondays, and Mercy actually asked me, I'm like, I haven't said it, I probably will in December because this is the end finals. I have a 20-page paper driven developmental. I probably, the thing of it is, I might not only do it a little bit because then you say the first thing of nursing is only one class.
And then next is
You're gonna get bombarded.
Yes, oh, for sure. As long as the damage wasn't too severe. okay?
Or like this class to be
I did, okay, it is.
So if I had to leave it.
Hey, here, no, here's the here, yeah.
How long is it? Next semester, I think it's gonna be March. No,
How many
like,
people?
like around.
I don't know what slide.
Okay, that's so.
Yeah,
How many semesters do you have?
total is 4.
Right. Right.
I just wanted to let you know.
Right, no, I appreciate it.
About 3
Yeah, I
semesters.
know, I understand, that's why.
Right, yeah, no problem.
Thank you.
You're welcome.
It won't be bad, I think, once I start.
So what is the first one, classes, and then the site class two?
Well, this one is this one class, and then next semester it'll be like pharmacology and some other shit. And then, I don't know about this summer. They're different. I got
Oh, you already had it? Why don't they let you take like pharmacology with the first semester?
That's how they used to, they're like really individuals. Because when I was gonna do the years ago, the first semester was dosage and calculation, transition class. And that was it.
Now there's 4 semesters?
Oh, it's
Okay,
basically like.
here we go.
Time.
Yep, exactly.
Except for the first semester.
Plural, infusions. So, I want you to listen to what I'm saying. There are, so this is confusing. So pleural effusion is fluid going in. Some people would call a whole lot of blood is a trauma. Some accident happens. And, the pleura tears and in goes a bunch of blood. It's perfectly legitimate to call that also a pneumothorax, okay? I'm not saying that you should or you shouldn't. A lot of healthcare providers do. Depends on where you're working, what they say. For testing purposes for GYM, pneumothorax is air, pleural effusion is fluid, okay? So, how much fluid is in the pleural space? And remember that irritating thing that I said? Just enough. Well, how much is just enough? Enough to keep the visceral and parietal pleura away from touching each other so they could be slick and smooth to be able to slide past each other without the membranes ever touching each other. So for most of us, that's roughly 5 to 15 milliliters, okay? Is it important to know? Yeah, you guys should know it because it might give you a question where it gives you a number, so you should know it, okay? So listen, while we're at it, if you're Shaquille O'Neal, 5 to 15 milliliters, no. His lungs are probably 50 to 70 milliliters of fluid because he's got ginormous lungs, okay? So it's relative. Does that make sense to everybody? Okay. So, just to revisit some terms from Patho 1. So, what's a transudate? So, there's all kinds of fluids that can be in the pleura, right? So we're going to look at some of them. Transudates could be in there. What are transudates? Stuff that has very low protein content. Why is it important? How do we exert osmotic or oncotic or colloid pressure with proteins? So if we have transudates and they're very low in protein, that means we don't have a whole lot of osmotic or oncotic or colloid pressure. So what the hell does that mean? Stuff's going to leak right through the vessels and the tissue and fill up the space. Make sense? Okay. Jim, you didn't say anything about specific gravity or low in lactic dehydrogenase. Right, you don't need to know that. It's too complicated, way too much information. Then why did you put it here? So someday when you're on the floor, you know. Okay? Who gets transudates? So people who have cirrhosis of the liver who have ascites, they're the ones who get it. Okay, it's a big one who gets it. I don't care about mixed edema, and I don't care about nephrotic syndrome. We're going to talk about nephrotic syndrome in the renal unit, so forget it today. Exudates, super jacked in protein. What does that mean? Well, they exert an enormous oncotic or osmotic pressure. So what does that mean? Listen, if you get exudates that get stuck in the pleural space, what are they going to do? They're going to draw fluid out of the surrounding tissue so that the pleural space gets filled with more fluid. Does that make sense to you guys? Yes? Okay. Where do you see that? Malignancies, infections, and some of the crazy stuff that we looked at in the first unit of part. Okay? That's the only takeaway. Empyema. Okay, not empanada, but empyema. So what is that? Okay, well, that's just pus and stuff. All right? Does that make sense to you guys? So what does that do? Well, that is super high in protein, like the exudates are, and so that exerts an incredibly strong oncotic pressure, and so fluids come out from surrounding tissues. The pus causes the pleural space to get filled with more fluid, right? Hemothorax is obvious what that is. It's blood, or blood and fluid, okay, that fills it. I don't care. Jim, you didn't discuss the bottom bullet points, right? You don't need to know that, all right? So, chylothorax, I'm not testing you on, okay? So, this is Patho 1 stuff. And we already talked about this in the cardiac unit. The whole point of all these fluids is they exert certain kinds of pressure. So either the vessels or the tissue is leaky, or they encourage leakiness so that the pleural space gets filled with fluid. You guys with me? Okay, yeah, Chris?
So these are found when the pleural effusions actually happen, not in a normal situation, correct?
Yeah, hell yes, yes, good point. Yeah. We're not taught, you don't have exudates and transudates and empyemas, hopefully, in your pleural space. So these are only in pathological states. But we have different pathological states that release different substances, and different substances behave differently in the pleural space. Make sense? Okay, cool. So what does this look like clinically? Guys, this is freaky, okay? I mean, obviously, if my daughter, God forbid, who's a peanut, ever had a pleural effusion of 300 milliliters because she's so short, she would feel it, okay? Shaquille, no way. What about the rest of us? Notice I'm throwing myself in the data pool as the rest of you guys who are almost everybody's taller than me in this classroom. So the rest of us, we literally can have up to about 300 milliliters. Is that an important number? Hell yeah, it is. Why? Because these people, I mean, 300 mils is a lot, right? So 10 cc's, right? We all know what 10 cc's is. Well, 30 times that. So we can have up to 300 mils in the pleural space of fluid and be relatively asymptomatic, or at least not aware of it, not as conscious of the symptoms. When we start becoming symptomatic, as the amount increases over 300 milliliters, what happens? Well, dyspnea happens. Can't breathe right? That makes sense. This is around here, it's around the lungs. If you fill this up, that means what? The lungs aren't expanding the way they used to expand, right? That's the reason why it's a restrictive lung disorder. So you can't get enough air in. And people begin to recognize that they can't, and they become anxious, okay? The other thing is too, when this happens, when somebody gets a pleural effusion, that's a decent one, decent sized one, it actually feels very similar to the way people describe pneumonia. Oh my God, it hurts. It really hurts when I breathe. And why? Because the more this gets ballooned out and the more it compresses against the lung, it's actually causing irritation to the lung parenchyma itself. Does that make sense to everybody? Yes? Okay. Don't do the dry cough thing. I'm not going to talk about dry cough, okay? The thinking behind that is, and it's true most of the time, but not always, the thinking behind that is, well, where's the fluid going into the total space instead of in the alveoli? Does that make sense to everybody? Okay. So, you do not hear breath sounds, well, duh. And it's dull to percussion, right, because now there's fluid in there, we already talked about that. Make sense to everybody? Okay. And if it's big enough, listen, if it's big enough, you can get lung collapse. And that means what? You get the tracheal shift to the contralateral side. Again, okay? So when you do an x-ray, it can look a whole lot like what we already saw. But you see densities. What does densities mean? You see stuff, it shows up on x-ray in the pleura. So the pleura, the boundary length is bilateral, lights up. You see lots of white stuff, and then you can see infiltrates, okay? And what does that mean? It just means there's fluid with junk in it. That's all that means. Does that make sense to you guys? You're not ever supposed to see white glass or snow, okay, in a person's chest. You don't need to know this, but I'm going to explain the thoracentesis. Why do you, not testing on that. Why do you do the thoracentesis? You want to find out what is in the fluid so you can figure out how they got to that state. Because often they're unconscious and you can't ask them questions. Does that make sense to you guys? All right. So, treatment. Well, obviously you want to identify whatever caused it and get rid of that. And you want to reinflate the lungs if possible. And you want to get the fluid out. Okay? Now you might not have analepsis, but you might. But you want to get the fluid out of the pleural space. In an adult, you always put a tube in the drain. In a kid, it's super controversial. Any idea why? Is what? It's because, yeah, there's such small space that when you actually insert the tube, you could actually do substantial tissue damage. That's why. So listen, some of you may have already or will see it get stuck into a neonate or a 2-year-old toddler. Why? Sometimes you have to risk it. Okay? That's the bottom line. All right, don't care about that. Polio, don't care about that. ALS, don't care about that. Muscular dystrophy, I care a whole lot about that. Okay? So, 1 out of every 3,500 birds. Listen, look up the numbers of how many kids are born a day in this country. Just a day. And then you realize, and then weekly, monthly, yearly, you realize 1 out of 3,500, that's a pretty high number, guys. Okay? So there are multiple kinds of muscular dystrophy. And, what? Oh, okay. So, well, I wanted to go to this one.
No, like the whole thing went black.
Projection went off, but it's not on.
It's back on now.
Oh, God. For real?
Yeah,
Oh, it's still on.
but it came on again.
That's thanks, Kara. Jim, I see it, guys. No, Jim, it's not there. Quick, somebody give me some Ativan. No. I'm joking. So, what's the deal? Duchenne's muscular dystrophy is the really bad. Okay? And, oh damn, I don't have other stuff on here. Shit. So, bottom line is, in cells, okay, that make up a bunch of different things, but make up muscle tissue, right? We've got all these fibers, we've got proteins that make up, that are part of the phospholipid bilayer membrane, right, the cell membrane. We have this protein called dystrophin that works as a cross-linking, reinforcing protein. So, there are many different kinds, or a number of different kinds of muscular dystrophy, and there are gradations of badness. Duchenne's is the worst. It's X-linked recessive. Do I need to know that, Jim? It's X-linked recessive. Yes, you need to know that, okay? And what does it do? Those people either don't make any dystrophin, or they make really funky dystrophin in very small amounts. So what does that mean? There isn't the reinforcement of the fibers that make up the sarcolemma, the plasma membrane, for muscle cells. And they deteriorate and the inflammatory process happens. So the muscles actually begin to turn to fat. That can happen, of course, to the diaphragm, and then they can't breathe and they die. Okay? Guillain-Barré syndrome. 45, 46-year-old super muscular construction guy comes in. Hey, did I tell you guys a story, by the way? Yes? Okay. Yeah, so listen. Usually legs start to get weak, goes up into the arms, and there's weakness. The good news is that the death rate is only about 3 out of 100, only, thank God. Most people spontaneously get better, and the only thing you do is make sure that they got electrolytes and nutrition. You get support treatment, really not much you can do. And almost always it's somebody who has recently suffered from some sort of microbial infestation. And we know Campylobacter jejuni is definitely linked to it, but we also know that Zika virus is too. So if somebody tested positive for Zika virus, if somebody has the antibodies, they never got sick, but they have antibodies to Zika virus, does that mean that they're at risk? They're at a higher risk of getting Guillain-Barré syndrome, okay? And bottom line is, the peripheral nerves get demyelinated, and then those people who spontaneously resolve, those get remyelinated. Wait, that doesn't happen, Jim. No. Nerves, the axons don't regenerate, but the myelin does. Okay, remember that. Okay? Sexy test question? Oh, hell yes. All right? Yeah, Jan.
Why do they ask you if you have this when you get the flu shot?
Say that again?
Why do they ask you if you have this when you're getting the flu shot?
Okay, so it doesn't cause it, but if you get the flu shot and you're very sick at the time that you get it, so you sign off, right? No, I'm not sick today. What happens is that may stress your immune system and you can't combat the thing that's making you sick because you gave it another load. It's got to respond to the flu shot. Flu shots don't harm anybody. They do not harm anyone unless you're allergic to eggs or chickens. So flu shots do not. So is there an incidence, a higher incidence of people who get a flu shot who actually get Guillain-Barré? Yeah, there is. And then when you actually find out when they're sitting there dying in the hospital room, so when you got that flu shot, Mr. or Ms. Doe, and you checked off the box that you weren't sick, were you sick? Might have been. Oh yeah, I had a sore throat and had a really bad cough. But I knew that the only day that they were giving free immunization at C&M or at UNM, I had to go in and get free immunization because I wanted to get it. That's what it means. Make sense? It is not, the flu vaccine does not give you Guillain-Barré syndrome. Okay? Guillain-Barré syndrome almost always arises because of a previous, and almost always a viral thing. Okay? So, fine, talk about it. Myasthenia gravis. So listen, the best way to do this is to show you guys with a very high-tech 2017 New Millennium, I'm a New Millennium kind of guy, demonstration in class. Here we go. This is the neuromuscular junction. Okay? This is the part that's on the muscle. In order to get skeletal muscle to contract, we've got to send it a signal. What's the signal? It has to be an electrical signal, right? So that means we've got to open up gates here to get sodium to go in so that the sarcolemma can be polarized so that we can get the sarcomeres, so we can get the T-tubule system to transmit the signal and get calcium set free to bind to the sarcomeres and so on, right? Okay, cool. So how do we get that signal there? Well, at all skeletal muscle junctions, neuromuscular junctions, we have a nerve, and then we've got the muscle, neuromuscular junction. The neurotransmitter from this axon and synapse is always acetylcholine. So, what is myasthenia gravis? It's an autoimmune disease where the person who has it makes antibodies to the, and here's the big, I did all that intro to say this, to the postsynaptic acetylcholine receptors at the neuromuscular junction. So I'll say it again. Okay? So first let me demonstrate, where are we having the problem? We're making immunoglobulins against the acetylcholine receptors that are postsynaptic, right? We release acetylcholine, it's got to attach where? Acetylcholine receptors, right? So, myasthenia gravis is an autoimmune disorder where we make antibodies to the postsynaptic acetylcholine receptors where neuromuscular junction, okay? So what does that mean? Well, when the immunoglobulin binds to the acetylcholine receptors, it blocks acetylcholine from being able to bond to the acetylcholine receptor. When we've done that, that means we can't open up the gate and get sodium to come in, which means that that muscle can't depolarize, which means we can't get an action potential, which means we can't get a muscle contraction. Does that make sense to you guys? So I said it all linearly, purposely. One second, Chris. The other thing that we do is not only does that immunoglobulin bind to the acetylcholine receptor and block acetylcholine, it also destroys the acetylcholine receptor. So eventually there are no acetylcholine receptors. Chris?
You answered my question.
Okay. Yeah, it does both. It does both. Okay? So why is it in the restrictive lung disorder problem? Here's why. Because if you block and destroy the postsynaptic acetylcholine receptors at the neuromuscular junction, you can't get the message to where? Diaphragm, external intercostals, and so on. Make sense? Okay. So, kyphoscoliosis. So, kyphosis is anterior posterior bending of the vertebral column. Scoliosis is lateral bending of the vertebral column. Kyphoscoliosis is both in one patient. Does that make sense to you guys? So kyphosis is anterior posterior bending. Scoliosis is lateral bending. Kyphoscoliosis is both. Okay? Now, it can come about in many different ways. People who have muscular dystrophy develop it. Okay? People who have Marfan syndrome, which is a collagen disorder, if you have Marfan syndrome and you have a collagen disorder, well, we have ligaments and tendons and stuff, right, that all go to hell, potentially go to hell. They're made not as thickly, not as reinforced as you want them to, so that's an issue. Neurofibromatosis and Friedreich's ataxia, I don't care about at all. And polio also can cause it. Okay? So, who tends to get it? A lot of it's idiopathic, and it's usually found in females. Females 7-to-1 ratio over males, and it's teenagers or older. Okay? It can be congenital, but listen to me. To just forget everything, I'm going to tell you what you need to know in words. The slides are accurate, but too many words. So, when a child comes in, right, I've already said this. When a child comes into a pediatric practice, it's a well visit, it's an immunization visit, it's a cold visit, whatever. Child comes in, you should always, every flipping time a healthcare provider has access to a kid, you should always look at the spinous processes of the vertebra. Do you see any funky deviation? That's when you catch it. Then you also put your fingers on either side of the spinous processes and palpate the transverse processes of the thoracic and the, all the way through to like L1, L2, the vertebra. What are you looking for? If there's a slight deviation, that's when you can address it. And here's why. because you can teach posture. You mean, if I have bad posture, I can actually get this? Hell yeah. A lifetime of, like this, walking around like that, you actually retrain your muscles. So that means what? Well, you can do posture training. Don't buy waist trainers with girls, they don't help. Okay? They don't. And they're super dangerous and bad for humans. Okay? Which actually sounds like a creepy statement, like they're used on anything other than humans, so I didn't mean that. So you retrain. If it's difficult to retrain, what do? There are special vests that are weighted vests that can help retrain muscles and tendons and ligaments. So listen, if you don't catch it and the child continues to develop, then they develop in a really awkward way, and then eventually, you guys don't have to know all the rest of the detail that's in the slides. Eventually, you have only one option. If you have somebody that's as bad as the pictures I'm going to show you briefly, well, that person's beyond surgery. But what would you do for surgery? You'd actually break their back. And surgically break their back and insert rods on either side on the ventral surface of the transverse processes to keep them propped up in place. But that means they lose their ability to move, right? Yeah, they do. But what's the problem if you're like this or you're like this? The problem is that you've reduced your lung capacity. You reduce the total volume of your thorax, which means you have limited capacity to expand. And if you have limited capacity to expand, it's a restrictive lung disorder because you can't get enough air to come in. Does that make sense to you guys? That's why it's a problem. Okay? So, this poor thing, it's horrible. Okay? I'm telling you, it has 7-to-1 in females compared to males. And pediatric practices are absolutely on the front line to be able to detect most of this. Not all, but most of it. Okay? So, don't care about the rest of that. Ankylosing spondylitis. We actually have it occurring here in the state, but I'm not going to talk about it.
I have a quick question.
Yeah, Julie.
Did you mention why females are more
I
susceptible?
didn't mention why.
Why?
And that's complicated.
Okay.
That's a great question. But that's like 15-minute discussion. No, and so no. Okay? Jim, you're going past ankylosing spondylitis. Yes, aren't you happy? Okay? Yes, of course. Flail chest. This one's easy. 2 different spots in the rib cage, 2 distant sites from each other, have been fractured so that part of the rib cage is free to move. Okay, does that make sense? When are you going to see that? Don't wear a seatbelt when you're driving and get into an accident. You see that all the time. Okay? As a matter of fact, when Chris and company get to the scene, and that's what's happened, there's not a whole lot you can do sometimes, right? Right. You see all kinds of really weird chest motion and then no motion. Okay? Why? Because the rib cage is supposed to be tethered. If you set it free from its moorings, you can't generate the volume increase to get air to come in. Make sense to you guys? That's the problem with it, okay? Jim, is that all we have to know about? Yes. Right? If I can't, listen, you know what, I already prefaced everything with the introduction last week to this chapter. So, you set the ribcage free, you got flail chest, we know what happens. Okay? Disorders of obesity. Nobody ever wants to talk about this, but we have to. Okay? It's not, I'm not an adrenaline, I'm a
Don't lie,
I can't say
Jim.
that. Okay, so I can't forget it. Anyway. Disorders of obesity, so here's really the point I was trying to make. It's sexy to talk about, you're in trauma unit, you're in the ICU unit or whatever. I mean, it's sexy stuff, right? The urgency, oh man, saving lives and not saving lives. That's the Messianic complex, by the way. You can see therapists for that. For real. okay? So disorders of obesity isn't sexy compared to that. You're actually saving lives when you talk to people about their obesity. For real. You really seriously are, okay? Or at least you're helping. Listen, some people are like, oh yeah, man, I'm sick and tired of thin, isn't it? Well, I'm not talking about being thin. It's not about that, okay? It's not about Hollywood, okay? Thank you, Harvey Weinstein, right? It's not about Hollywood at all. It's not about thin as in. It's about we have like gazillion pieces of data that show that if you are obese for your friend, no, I'm a big bone person. Oh, bullshit, okay? Everybody in my family's big bone. BMI is BMI, guys, okay? You stand on that magical electromagnetic scale that tells you a number that's radically different than the flippant scale at home tells you, and it gives you a readout. It automatically disarms come from the line of big bone people. If you have a high BMI, even if you come from a line of big bone people, you have a high BMI, period, okay? A lot of people think incorrectly. So I want to start that sentence again. A lot of people think incorrectly that if it's muscle mass, that's okay. It isn't. I had a man who came into my AP2 class 3 or 4 summers ago here. He's the single strongest, most muscular human I've ever met in person, okay? He's maybe an inch taller than me. We'll say his name is John Doe. 46 years old, about an inch taller than me. He weighed exactly 100 pounds more than me. And he was, I think at the time, it was like 2 or 3% body fat. Hey, that's insane. Now we all know he did roids, right? There's no way somebody my height. No way. If you eat all the right stuff in the workout, it's never happening your way, okay? He literally had to turn sideways to walk through these doors, okay? And he got really pissed that his PCP told him, John, you gotta cut the weight down, bro. You're too big for your frame. But it's muscle. All the muscle mags say it's okay, right, because that's science. All the trainers say it's okay. I'm not disparaging trainers. I think it's really cool. Sit for an exam 2 or 3 days, you can become a trainer. Get a book, read up on it, and become a licensed trainer. You guys have already done this semester about 1,000 times more work than what it takes to get licensed to be a trainer. Okay? I'm not dissing them at all. Totally respect that kind of commitment. I love athletic accomplishment. The motivation is very inspiring to me. But the bottom line is BMI is BMI, guys. Okay? How are you for your frame? Well, my people are fill in the blank. Nope, you're using excuses. So, general rule of thumb, guys should be under 20. Nice. So I had a student in my Patho 1 class. Now, he wouldn't have been in your guys' Patho 1 class, so those of you that went to Patho 1. So it was a couple semesters ago, who's actually in PA school right now. Really brilliant man. And he was part of a clinic, volunteered in a clinic down in South Valley for about 1.5 years. And what they did was because there's a high correlation, if your BMI is too high, usually your waist size is in excess of certain averages. Not the averages that department stores or TV shows you, but that healthcare data shows you. And what they calculated, and it corroborated, because they work with the CDC, and I do some other crunching for the CDC here, it corroborated what we see at the CDC. In New Mexico, almost 2/3 of all adults are far beyond their target BMI. Okay? Far beyond it, which explains why we have sky-high diabetes, sky-high cardiovascular problems, and everything else, and respiratory disorders. So, a BMI of under 20, you guys can look at the charts. So almost 5'5". Okay, almost. And what was that? Thank you. And I, for the last 35 years of my life, I weighed religiously, literally, 163 pounds plus or minus 2. That's, I don't know how, but that's just what it is. So, I have lean muscle mass. It's not fat, but I'm in a good BMI. But if you look at the figures, somebody my height it should be like 135 to 140 pounds. I mean, this guy takes like in 4th grade. Okay, so am I at risk? Of course I'm at risk. Less risk, because what's the really scary number? 30. Okay. Hey guys, look at that. People who have a BMI that's greater than 30. Increased mortality rate, 50 to 100%. So if you're listen, the average BMI for a male in this state, I believe, is 43 or 44. And for a woman, it's about 46 or 47. You're past 30, yeah, right, exactly, scary shit. You're past 30, just a smidge past 30, there's a much greater chance that you'll die of some underlying disorder than if you were between 20 and 25 for BMI. You mean the number difference is, it's not that big of a number difference, it's all the difference in the world. So what's the goal? You start eating healthy and exercising today, and you drop that BMI. Because it's its own risk factor for, guys listen, it's its own risk factor for cancer. Cancer, cardiovascular disease, and diabetes. I don't know, but you listen, it's not about how long you live, it's about how healthy the years that you do live are. There are lots of people who will make it to 80, 90 years of age who have been sick the last 30 or 40 years and constantly going to doctors and can't go upstairs, can't do this, that, and the other. That's what we're talking about. Why is it in the respiratory unit? So we're going to get back to the slide in a second. Why is it in the respiratory unit? Because obesity begets sleep apnea. There is a sky-high correlate. People do sleep studies all the time. I wake up, I'm falling asleep during the daytime, I can't understand why I can't sleep at night. I toss and turn, my partner tells me that I'm whatever, okay? Why? Well, if you're past your target BMI, you have what? Fat deposits in your neck. You have extra blood vessels. Why? Well, because you have extra tissue. And what does your body do? Got to get oxygen to that tissue, so we're going to build, by golly, more blood vessels. Oh, that's right. More blood vessels, greater mass, we need higher oxygen delivery, so we're going to create more red blood cells. So you have a relative polycythemia on top of it. But the heart can only do so much work. Your heart wasn't meant for a BMI of in excess of 30. Your heart was meant for a BMI of between 20 and 25 at the most. You hear me? Okay. So, Jim, I can't help it. I read New York Times just like you do, and it tells me that my hormones are out of balance, leptin and ghrelin. So I'm here to tell you, I don't want to show hands, but most of us have fasted either for religious reasons or because we got sick, we had no choice, we didn't eat, right? And, pregnant moms, if you get really sick, for example, with chicken or whatever, it might be the case that for the rest of your life or for a period of time afterwards, after Junior comes out, you're like, if you show the chicken one more time, Jim, you're dying in the middle of the night, okay? So, and things are happier in my household now, okay? But during those first few years, man, it's scary. Listen, what do? You're not eating. Right. Wow. You exercise self-restraint. Holy shit, right? Is it Taco Bell, or do I go, you don't have to go to Whole Foods for crying out loud? Well, now that Amazon owns them, maybe, but, right? So, you don't have to go to Whole Foods, so instead of Taco Bell, how about getting some tomatoes? Oh yeah, and ranch dressing and some lettuce. Lettuce is worthless, and ranch dressing kills people. Okay? So, how about some chickpeas? How about some lentils? carrots. Doesn't that sound good? Go screw yourself, Jim. Right? Okay? That's how you do it. We're not bound by leptin and ghrelin. We're not. So yeah, they make us hungry, or they say we're satisfied. So hey, one piece of pie from Village Inn, chocolate silk pie. Coincidentally, one piece is almost 666, I love that number, 666 calories, most of which are fat. So Jim, you mean to tell me that when people have bought a pie and come over to your house, no one that I know does that to me. Okay? Because I'm a pain in the ass all of my waking hours with everybody. Hell no, 666 calories for a slice of pie, and it's mostly saturated fat, but it tastes so good. Oh my God. Get reprogrammed, for crying out loud. Okay? I'm serious, guys. I'm dead serious, because that stuff kills you, and we have control. We're not victimized by our hormones. Sorry, we're not. Okay? I just have this craving for meat. Right. So unlearn the craving for red meat. Okay? Right. Shortly, I already talked about this. Listen to me. Obese people often, they use urgent care. Obese people, there's data on this, not Jim's opinion. There's data on this. You look at urgent care data. Who are the people complaining the most about having headaches and they're sleepy during the daytime and there's breathing problems? All things being considered, is people whose BMI is in excess of the target. Okay? Why do you get a headache? There are many reasons why people get headaches. Nutritional deficits. Nutritional deficits, how they get obese? Well, they're not eating all the healthy stuff, right? So, guys, I'm not dissing any of you. But I would be remiss as a teacher if I didn't tell you the truth and what the data shows. And as a healthcare provider, it's your responsibility to not peddle fairy tales and bullshit to your patients. A healthcare provider is often first a teacher. And how do you teach? The way you teach is by living it, not by talking it. Okay? So if you're obese and you reek of cigarettes and you got that sick, sweet smell because your liver's pickled because you drink too much, and you are borderline diabetic, your patients aren't going to listen to you. No way in hell. They're not. Okay? It's not Jim's opinion. Millions of data points on all this stuff, guys. All right? So, this is not my word. Diagnosis, self-evident on exam. Okay? You don't have to embarrass somebody. Hey, what's your BMI? Do you know what your BMI is? You can tell. Okay? Most of the time. You get this guy who's incredibly muscular who weighs 265, and he's just an inch taller than me, and extremely aggressive personality. So he literally, at the end of one class, came and he slammed his fist on the podium, and he's like, "You didn't tell me this bullshit white doctor told me X, Y, and Z." He's like, "Dude, man, you can slam anybody you want, just have you arrested, give me a hassle on me, but you're obese, according to medicine. How can you tell me I've won all these?" He's showing me pictures. Dude, I don't care. It's 100 pounds too much for your body. So how does he get rid of it? Oh, well, that's the problem when you write it out. There's a whole separate set of problems there. Okay? So, aerobic exercise. Now listen. Oh, Brianna.
Somebody was just lady yesterday and she was doing a pretty good reading really short. And we had to pull a sheet on her and she developed with too much trauma. And I was wondering why the obese people develop it.
Well, that's okay. So that's a great question. So I actually talked to a physician who shared the following story with me a couple of weeks ago. A lady comes in, she's 64, 65 years of age. All that she remembers doing is just bumping one of the cabinets with her pillow. Here, okay? And a lot of sweet grandmas have a tricep pillow there. But she had the pillow there. All she did was she just nicked it, right? And after the course of the day, when she passed out, she reset it. Somebody found she was septic. The tissue becomes so friable. Why? It's stretched. And it's significantly weakened. And so any kind of pressure that normal tissue is able to withstand, you've got all this extra tissue that's under greater strain to accommodate the larger mass, and it takes a lot less to harm the tissue. She just bumped a corner, and she literally developed, she couldn't see it, she developed a gaping hole that was 2.5 inches in diameter, and it got infected. So, I just want to say this. I don't want to, if you don't email me about gastric bypass, there's plenty of stuff on the web, good literature, National Institutes of Health, Medline, etc. National Institutes of Health usually give you links to other things too, where you can read gastric bypass is super dangerous. The rubber band thing is super dangerous. That's it. I'm not gonna say anymore. Okay? If you have to do it, you do it, whatever. That's super dangerous. Calories. Jim, somebody did not become obese overnight. It took a while to become obese. What's the moral of the story? You don't drop weight rapidly. You do it slowly, okay? Yeah, but when I started eating healthy, Jim, I lost tons of weight right away. Well, so here's the deal. That means that's water weight, the fast loss, okay? For all those other people who are trying hard to lose those extra 3 or 4 pounds that seem impossible to take off, that's not water weight, that's actual mass you're trying to get rid of, okay? So I'm not talking about getting rid of the water weight, I'm talking about the regular other stuff. It took a while to put it on, you take it slowly to take it off, so you don't get what we'll talk about in the next unit, the damage with the liver, okay? How do I lose a pound a week? Drop 500 to 1,000 calories a day, okay? And exercise. You lose it slowly, all right? And then when do I get to reward myself? The reward is your health. Okay?
Ice cream?
What?
Ice cream?
Wow, Brianna. Ice cream. Pie and ice cream. Yeah. Okay. Thanksgiving. We eat delicious meals at Thanksgiving, and you wouldn't want to come over. Okay? But it's super healthy and it's delicious. Because I'm not interested in killing the kids. For real. I want them to have healthy pets. Okay? And it's not, I'm serious, it's not about being thin. It has nothing to do with it. Exercise, don't worry about how you look. Okay? Screw anybody who doesn't compliment you or thinks that, oh, you're a little, well, screw them. Don't have them as friends. It's about exercising and eating healthy, period. Why? Because long after I'm gone, I want my kids, when they're my age and older, to not have to deal with what they've seen friends, parents, and relatives deal with. Dying is easy. Being sick for 30 years, completely laying down with sickness sucks. Okay? Pneumonia. What's the deal with pneumonia? Well, you get some kind of agent that gets in to where? In the lung parenchyma and ultimately also in the alveoli. Okay? So they multiply and you get an inflammatory response. Wait, Jim, is everything in life really the inflammatory response? It is so much the inflammatory response that Dr. Oz, I don't listen to Dr. Oz. I think he's a charlatan. Well, I don't think so. But Oz and Rosian, or how the hell do you pronounce the other guy's name, they release all kinds of stuff. And when you're my age, you get shit from AARP. You get shit from AARP reminding you are no longer under 55. Okay? And I get in the email, unsubscribe. You call them and you tell them, I still get the shit every day. Okay? And so, before I swipe to delete it, what do you see? Oz is talking all about getting rid of putting stuff in your body that causes inflammation. Why? anytime you have ongoing inflammatory process, you're at risk for cardiovascular issues, respiratory issues, and cancer. So, ice cream, inflammatory. Cow's milk, it's meant for cows, man, let them have it. Cheese, Jim, you're part Latino, man. Come on, what do you do about queso? I have queso like 6 times a year. That's it. I'm 56, man. I've seen people suffer on a hospital bed. I've seen people die, friends die from cancer. No thanks. But it tastes so good. That means that you can be duped. I don't like the feeling. I'm from the hood. That feeling makes me feel, I don't like feeling that vulnerable. Okay? So, what kind of infectious agents? All kinds of infectious agents. Where do you get them from? Somebody sneezed on the case study that they handed me and I got sick. Right? Yeah, it can happen like that, right? It does happen like that. So, you get it in, you aspirate it in some way, and you get the inflammatory process, and then there's all kinds of things that can cause it. And then you've got the inflammatory process destroying lung tissue and alveoli. Look, there is community-acquired pneumonia. Hey, one kid gets it at a Head Start program, every kid gets it at the Head Start program. Okay, and guess what? They bring it home to mama and papa, all right? And worse, to grandma, who takes care of everybody, and she's in her late 60s, early 70s, and her immune system's compromised. Great. That's how it goes, okay? Hospital acquired. It has been estimated that if you are in a hospital overnight, you have to stay in a hospital. If you're in a hospital for 3 or more days, you are dramatically more likely to get pneumonia, okay? And hospital-acquired pneumonia sometimes is pretty resistant to antibiotics, depends what unit you're on before you get it, okay? But everything is sterile in the ventilation system. Who's sterile? Not so much, okay? It can obviously come from bacteria. I don't care about gram-positive, gram-negative. So every year now, many years ago, there was an American Legion convention in Philadelphia. And there were 276 or something like that, some ridiculous number of people that were in attendance there. They got very sick, and they got fevers. They got all kinds of abdominal symptoms. A bunch of people developed hepatomegaly. And one of the things that united all of them were they got pulmonary infiltrates. And quite literally, I think the very first time it was discovered, I think all 200-something people died. Okay? And what they discovered, the cooling towers in the hotel, Sheraton Hotel, whatever the hell it was, in Philly, were completely cold. So, Legionella proliferated and came through vents. Every year now, we're getting more outbreaks of Legionella. You mean, Jim, portable water condensers and cooling towers wouldn't happen with smart coolers, right? So, next slide.
So what actually causes Legionella?
Say it again, the leading cause?
Yeah.
It's the Legionella virus. And that's why, and it was so named because it was first discovered at the Legionnaires' convention. Okay? Does that make sense to everybody? Right. So, there's this thing called, quote, walking pneumonia. So, some healthcare providers incorrectly tell people, so it's 3 of the cases, not legal cases, consulting cases that I've worked on in the last decade here. So 3 of the cases were somebody goes in and they're told, hey, you got walking pneumonia. They're told by a physician and then the surrounding healthcare staff affirming the physician's diagnosis. You got walking pneumonia, it's totally good. Walking pneumonia is viral pneumonia. No, it's not. Viral pneumonia is viral pneumonia. Bacterial pneumonia is bacterial pneumonia. Walking pneumonia is bad pneumonia, but it's just not so bad that you don't have to be hospitalized and put onto an into an oxygen tent or have a nasal cannula. That's all that walking pneumonia is. It means it's not as serious. Yes?
So basically, if you're not hospitalized, you have walking pneumonia?
It could be.
Okay.
You might not. You might have something else, but it could be. Exactly. If it's okay for you to go home and you don't need to be hospitalized, then it's probably walking pneumonia. Walking pneumonia has been used for decades, Chris. That's a huge soapbox of mine. Pet peeve. It's been incorrectly used. Oh no, dude, it's viral pneumonia. Walking pneumonia. So you can't really do anything, so you can go, no, that's not it. You could have bacterial pneumonia if it's not that bad, you don't have to be hospitalized, and you religiously take your medicine and do exactly what you're told, then that can be walking pneumonia. Okay? The big deal between viral pneumonia and bacterial pneumonia is that viral pneumonia tends not to have the wet productive cough. Whereas bacterial pneumonia tends to fill the lungs with all kinds of stuff. And that can be super dangerous and can kill somebody. I'm not saying viral doesn't, but viral, it can, but it doesn't necessarily always do it. Now, there is a special viral pneumonia called Pneumocystis jirovecii. If you ever see that in a chart, that's someone who has AIDS. Not HIV positive, they have AIDS. Okay? As a matter of fact, in the AIDS chapter that I couldn't cover over some of Patho, because we didn't have enough time, there's a bunch of different things. You know, you just can't, just because somebody's HIV positive doesn't mean they have AIDS, obviously. There are a few things that have to be present to be able to say, oh, that person has AIDS. If you detect Pneumocystis jirovecii, that's a confirming case of AIDS in somebody whose T-cell count is below 200. Okay? Does that make sense? Every single one of us have probably Pneumocystis jirovecii going in and out of our lungs from wherever the environment, and our immune system neutralizes it very effectively. But not somebody who's got immunodeficiency syndrome. Brianna?
Does pneumonia cause scar tissue?
It can. So when my dad was around, my dad was in and out of my life. He was around when I was 2 years old. He smoked all the time in the apartment. I got pneumonia as a 2-year-old. I ended up, getting better. It's in 8th grade, and I'm doing what kids in the hood do in 8th grade. And I got pneumonia again. I snorted a lot of blow in high school, put other stuff, smoked weed, other things. Age 16, got pneumonia again. And after that is when I began developing asthma. So, yeah, you betcha, it can cause long-term scar tissue and other problems, okay? So, I mean, look guys, inflammatory process. What's the moral of the story with all of us with the inflammatory process for the whole semester, for units we haven't even covered yet? The body does what it does, and we pay a cost for that immune system response. So it's just best not to either be exposed to certain things, or if we are exposed, to get medical intervention quicker rather than later. Make sense to everybody? Okay. So, there we go. So viral pneumonia, you don't get exudates in the lungs, so you don't have that productive cough. But listen, I can tell you, I remember what it's like to have pneumonia in my right lung. Okay? I remember very much, when I was breathing, it hurt so badly that I had to literally hold myself. And then you start taking shallower respirations and you're breathing more rapidly. And eventually get to a point you're not getting enough air in, you need to go to the hospital. Does that make sense, everybody? Okay. Oh, flu vaccine, right. How's the way to prevent it? Flu vaccine. What, Jim? Flu vaccine. How's the way to prevent it? Flu vaccine. Okay, it's that time of year. Please get immunized. I don't believe in immunizations. Should be helpful later. SARS. I don't care about SARS. although it happens almost every year religiously in China, okay? And it kills lots and lots and lots of people. So TB. So the number's wrong here, and I'm not gonna touch on this epidemiological number. It's actually more about 13.2 million people in the US are infected with TB. So here's the deal. The career you guys have chosen to go into exposes you uniquely to TB. You do work with gangbangers, homeless people, people who've been in prison. You're being exposed, you're at radically higher likelihood of being exposed to TB, okay? So, if you get pulmonary tuberculosis, it doesn't just go in the lungs, but this is the respiratory unit. If you get pulmonary tuberculosis, you need to get on a 9 to 12 month triple antibiotic dosage of, and I think, and listen, I'm not going to test you on the names, but rifampin and isoniazid are the two main ones, and then you play with the third one. Why do you give multi-drug cocktail? Because TB has been around a long time, and it's uniquely adept at developing drug resistance. So, people in Haiti, it's all documented. You guys should read Mountains Beyond Mountains by Tracy Kidder. It's about Paul Farmer, who's one of my all-time heroes. Got his PhD in anthropology, medical anthropology. He actually created the field of medical anthropology. And he got his MD, both of them from Harvard. He was a poor white kid from the Bayou who grew up, his home, he and his 5 siblings were raised in a bombed out yellow school bus. So when I hear people say, no, it's only all the rich white people that go to medical school or become, doctor or nurse practitioner, that's such a lame ass cop out. Okay? This dude was poorer than poor, man. And he got hot for Haiti because he and his family made the pilgrimage annually to be alongside the Haitian undocumented immigrants who were doing citrus fruit harvesting in Florida. And that was the way that his family got fruit, got to eat, got to pay for food. And Paul's a brilliant man and is radically socially active as you can possibly imagine. And he fell in love with Haitian people, and he's completely transformed the TB and the AIDS problem in Haiti. Haiti was blamed for, you guys need to know this, this is not random. Everything we know about TB now and the success and what not to do is because of Paul Farmer's work in Haiti, okay? And we blame the AIDS crisis, Americans blame the AIDS crisis and those slut bag Haitians. We're still holding back and have through Democratic and Republican presidential and congressional regimes, we've held back hundreds and hundreds of millions of dollars of aid that we've promised for years, and they've never gone there. And it's one of the greatest tragedies in modern history. What happened was the people from Hollywood and the wealthy people from the coast would go, and of course, if you're hungry and there's no work, and you've got a bambino or two at home, you've got aging parents at home, the only way you can make grocery money is by selling your body for an hour. That's a morally outrageous thing to do. And anybody who thinks otherwise can't be friendly. Okay? Those are some of the holiest people in the world because they know what it means to be shit on. Well, the bastards from Hollywood and the rich people from the coasts and our politicians were bringing the HIV and infecting them. And then they would give it to a partner without knowing. So in our infinite compassion with TB in Haiti, we would give them the World Health Organization, a fine world organization that cares for the poor of the world, said, well, we're willing to give rifampin and isoniazid and whatever the third one plans to be, clindamycin, whatever. We're going to give it to these people for 2 months because they can't afford it. So, and then they're going to have to pay for it. Right? You heard what I just said, right? You know what happens when you give somebody who has TB, active pulmonary tuberculosis, you give them those 3 drug cocktails for 2 months, and then they can't take it anymore, you drive the evolutionary engine. You didn't get rid of it, you gotta take 9 to 12 months of those 3 drugs. So you know, what was that? Yeah, because, so, for example, let's say you know somebody, John Doe, Brianna, and they go to a doctor, get a throat infection, they have a fever, they get, whatever, tetracycline, erythromycin, whatever they get. You should take this for 10 days. Okay, 3 days into it, hey, I feel better. And the erythromycin, God, the GI upset that I get, they tell me I'm supposed to take it with food. I'll be as big as a house if I have to take it with food. I'm gonna stop it. 6 months, a year and a half go by, get the same damn microbe, you take the same medicine or something pretty similar, and you do the same thing. Hey, this time I take it for 7 days, Jim. Okay, this is a 14-day dose, bro. Well, yeah, but it's feeling better. I'm saving it for when I get ill next time, so I don't have to pay your super fee to come in and get the prescription. Right. That's how bacterial resistance develops. TB resistance develops like that. So when you cut someone off and they don't take the 9 to 12 months, the second time they start taking the medicine, in most cases, if that isn't taken for 9 to 12 months, that's it. It's resistant. And guess what happens when you have bacteria-resistant, when you have antibiotic-resistant bacteria, you die. Okay? That's it, you die. So, mortality, 70 to 90%. You know what American anthropologists and physicians and historians said about the Haitians and about the people in Peru? If you've ever gone, Peru is amazing. If you've ever gone to Lima, Peru, you also ought to go through the slums. Mexico City, I love Mexico City, but you haven't seen Mexico City if you haven't seen the poverty. Okay? Philippines, the same thing. As I've gone to all those places, guys, that's seeing a place for what it really is, not just the nice suntan and the expensive drinks that you're in and out. And maybe it's heavy, you feel good about yourself. Bullshit. Okay? So what happens is those people don't get to take all the drugs for 9 to 12 months. And they're all gonna die. Every single one of them. Okay? And what do we say here? They're non-compliant. Those bastards, they're not compliant. We do everything for them. Non-compliant? You didn't provide the medicine for 9 to 12 months. Well, by golly, it's really expensive. Just the way taking AZT is really expensive. You can actually, if you can't afford the $2,400 a month in America to take the HIV medicine, living in Mexico, we provide it for free. Okay? That's badass. We provide it for free. Because of Paul Farmer, you know how much it costs to provide it to the continent of Africa, where probably 80 million people as we speak have HIV positive, and at least half of them don't know it? It only costs about $5 a day now. Wait, why does it cost $2,400 a month here? Right, why? Exactly. Okay. All right, so who gets TB? Anyone who's immunosuppressed, malnourished, been infected before. You're old. Immigrants, why? A lot of countries gave TB vaccinations, and guess what? They gave people tuberculosis. No TB vaccination works, okay? It doesn't. There is no TB immunization, okay? Anywhere where there's crowded living and there's any potential compromise in the ventilation systems, okay? So, It spreads everywhere, but when I go to, here you go. So listen, TB gets gobbled up by our alveolar macrophages. Now I want you guys to pay attention to this. It gets gobbled up by our alveolar macrophages. Well, macrophages, we all learned from Patho 1, they're amazingly powerful, and they can gobble up and kill everything. Run. They're successful in getting rid of TB. Often, how is it? Have you wondered how is it that somebody can have had a TB infection and be completely symptom-free for 30 or 40 years, and all of a sudden they have TB is active again and they die from it? How is that possible? Because the tuberculin it loves the high acidic and enzymatic concentration of the lysozymes that are in our alveolar macrophages. And they proliferate, and they're perfectly content to stay parked there for years. And the minute the patient experiences some immunocompromise, that's just enough of a trigger to let them loose. What do? They form this thing called the GAN complex. They form an inscribed surface, and they begin deteriorating everything that's inside. So that is called caseous necrosis, and then ultimately there's nothing there. And the symptoms are very famous, Dostoevsky novels from Russia, Tolstoy's novels, etc. People, night sweats, coughing into the movies, into a hanky, and there's hemoptysis, a little bit of blood, right? That nasty cough, fatigue. And I don't care about, so what's the gold standard? Sputum culture. So x-rays don't show anything, okay? Well, why do we go and get, a clean bill of health if I came back and they had the induration type 4 hypersensitivity reaction, right, from Patho 1. If I had the induration as positive and I do an x-ray, they give me a clean bill of health. They don't give you a clean bill of health. What they're saying is we don't see any GAN complexes, we don't see any caseous necrosis, so it's probably not active in you. And they will also take a look at your blood to see what kind of immunoglobulins you're making, okay? It doesn't mean that you can't come back and have active TB. So, I want to show this slide. So you see right here, there is this amazingly symmetrical, defined line that's curved, okay? The arrow's not pointing to the white infiltrates, it's pointing to that weird opacity. If you look at it carefully enough, you could actually see some of the rest of the lining. All of that part of the apex of that lung is completely gone. There is an encasement where the tissue is no longer. So there's consolidation, caseous necrosis, fibrosis, and consolidation. What does that mean? Tissue's gone. You have no more alveoli, you can't breathe air into it. Can't do it. Oxygen, carbon dioxide exchange. Make sense? Yes? All right. Goes back to the other stuff. That's it. We're done. Any minute papers? Next week is the test. I have people whose tests I'm going to pass back. We didn't get them. So please, Mariah?